Good afternoon, and for our viewers on the West Coast, good morning. Welcome to the webcast. Just a little housekeeping before we get started. If you would like to enlarge the video screen, just click on the icon in the lower right corner. To ask a question during the webcast, please use the chat box on your screen. Questions will be answered at the end of the presentation. Today, Jan Gnida, Director of the Patient Experience and Government Surveys Departments here at PRC, will be presenting part 2 of her 4-part CG-CAHPS series. If you missed the first, please visit prccustomresearch.com. And now here's Jan.
Hello, and thank you for joining me today to take a deeper dive into the physician quality reporting system, specifically as we look at the value-based payment modifier that is currently being phased into the Medicare fee-for-service physician payment system. As you heard me speak about in the first episode of this series, the most effective leverage CMS can use to make anyone do any survey is their checkbook. And the Physician Quality Reporting System, or PQRS, is one means of exerting some leverage toward physicians and medical groups. We're going to do a quick recap of how the CAHPS survey is being used for PQRS. Then we'll pull back the lens and take a broader look at PQRS as a reporting program. The Value-Based Payment Modifier Program, or VM, is a similar concept to value-based purchasing for hospitals, where the CAHPS results are one factor among many that are used to evaluate quality and ultimately to determine financial rewards and penalties. Let's begin with the survey instrument itself and the kinds of office visits that are expected to be considered by patients when they respond to the CAHPS for PQRS survey. The requirements for PQRS are defined in terms of the number of eligible professionals who bill under each tax ID number. We have 3 broad categories: Medicare physicians, practitioners, and therapists. And then you can see there are a whole host of different individuals who fall into each of those categories. Your medical group's GPRO administrator or PQRS coordinator has already registered the eligible professionals with CMS, so that person would know exactly how many eligible professionals are considered as part of your group. That person would also know the specifics of your group's participation in PQRS. The CAHPS for PQRS survey is built upon the CG-CAHPS survey developed by AHRQ several years ago, and it matches the CAHPS for ACO survey. Measures 1, 2, 3, and 8 are part of that CG-CAHPS core item set, so they must be included in any version of a CG-CAHPS survey. Measures 1 through 7 are the quality measures that will be evaluated by CMS to assess the performance of accountable care organizations. Measures 1 through 6 are also the measures that will begin seeing reported on the Physician Compare website in the fall of 2014. Measures 9 through 12 are additional questions that CMS believes are valuable for medical groups and practices to monitor. We've not seen the full scoring matrix for PQRS yet to know how they'll be incorporated into performance evaluation. CMS has contracted with the RAND Corporation to administer the CAHPS for PQRS survey in 2014, so we don't have a lot of detail yet regarding the timing and methodology and protocols to be used for this data collection program. We expect that for 2015, CMS will turn this work over to the survey vendors, like PRC. They'll establish a vendor approval process, and groups will need to contract with an approved vendor, such as PRC, to do the surveys for them next year. We're now going to take a few steps back and look at the big picture of PQRS. As I mentioned earlier, CAHPS will be one factor among many that are evaluated for PQRS. When thinking about CAHPS and its impact on your Medicare reimbursements, it's important to understand the context. CMS offers a thorough website, there's several pages, devoted to all things PQRS, seen here. I strongly encourage you to take a look if you haven't already and start familiarizing yourself with the information that is available. In particular, I recommend a couple of links shown on the left. The CMS-sponsored calls page provides a schedule of upcoming web presentations by CMS. These are a very valuable source of information, and much of what I'm sharing with you in this webcast came from these calls. This program still has a lot of evolution ahead, and it's important to keep up with the changes. PRC attends all of these calls as well, and will provide the CAHPS highlights to our clients. The other link of note on this page is the CMS Certified Survey Vendor link. If you are not the person responsible for patient experience measurement within your medical group, this page would give you a great introduction to what's ahead in the near future in terms of using a CMS-certified survey vendor as a new reporting mechanism for PQRS. The page doesn't have a lot of information at the moment, but this is where we'll expect to find information going forward as they expand the list of CMS-certified vendors beyond just the RAND Corporation. PQRS is organized around these 6 national quality strategy domains developed by the Agency for Healthcare Research and Quality, and there are 284 measures to choose from for the 2014 program. When registering your participation in PQRS, you must select at least 9 measures to submit, and these must cover at least 3 of these domains. By itself, PQRS is a pay-for-reporting program for all providers who submit Medicare claims. In order to avoid a 2% reduction in reimbursements for 2016, eligible professionals and medical groups must satisfactorily participate. This is accomplished by completing the registration I just described, selecting 9 or more measures, and then submitting data for those measures as outlined by CMS. The CAHPS for PQRS survey is equivalent to 3 measures and 1 domain, and you can probably guess which domain that is. Selecting CAHPS for PQRS will meet the requirement for measuring person and caregiver-centered experience and outcomes. Now, I just said the R word, requirement. So let's take a look at who is required to do the survey for PQRS and when. In this table, EP stands for eligible professional, and we looked earlier at the many different categories of patient care providers who qualify as eligible professionals. CAHPS for PQRS requirement began with data collection for 2013 for groups with 100 or more eligible professionals billing under the tax ID number. CMS administered the survey for those groups, and you'll notice that this continues for 2014. For 2015 measurement, we expect to be doing this work and submitting the data for these largest medical groups. Now let's look at the next segment, those with 25 to 99 eligible professionals in the tax ID number. Measurement is optional this year for those groups, and if your group chose to participate, CMS will also take care of all administration. For these groups, surveying will be optional again in 2015, but the difference will be that you'll have to use an approved survey vendor next year. The last segment to be incorporated are the groups with 2 to 24 eligible professionals. For these smallest groups, they may first exercise the option to administer surveys in 2015, and if they do, they'll need to work with an approved vendor for that to happen. We've not seen yet when measurement will be required for the groups in the 2 to 24 range, or for the groups in the 25 to 99 range for that matter. I expect it will be within the next 2 to 4 years. You'll recall I mentioned earlier that PQRS has its own incentive payment system, basically a pay-for-reporting system, where medical groups will not be penalized as long as they fulfill the data reporting requirements. The value-based payment modifier, or VM, sits on top of that. The VM is aligned with and is based on participation in PQRS, but it's a separate layer of evaluation and performance measurement. This is where we get to pay for performance. Again, for more detail regarding VM, I encourage you to visit the official page within the cms.gov website. The address is listed here. The program is much bigger than just the CAHPS focus we're going to take today, and the CMS website covers the whole scope. The value modifier was legislated in the Affordable Care Act, and it takes a phasing-in approach to being applied for physician reimbursements. Groups of 100 or more eligible professionals will begin receiving payments with the VM next year, based on their PQRS results from 2013. The performance period we're currently in, 2014, will be the basis for the VM applied in 2016, and this is for groups of 10 or more eligible professionals. And for payment year 2017, the phase-in will be complete, with all providers being evaluated based on their PQRS performance in 2015. You'll notice that the potential penalty for non-participation in PQRS is increasing over time as more groups and providers become required to participate. As I mentioned, we're currently in the VM performance period for payment year 2016. So let's take a closer look at the value modifier's potential impact for groups of different sizes. For 2016, we're talking about groups with 10 or more eligible professionals. The first branching point considers whether or not the group has registered to report results for PQRS for 2014. Groups had until September 30th to register their reporting methods. Groups that did not register will receive an automatic 2% reduction in their Medicare reimbursements in 2016. Period. End of story. Groups that did register will avoid this penalty. In addition, groups of 10 or more eligible professionals that registered for PQRS will also be subject to the quality tiering calculation. This is the pay for performance component, where quality and cost metrics will be evaluated to determine statistically significant differences between groups, not individual physicians and providers, but groups, and the value modifier will be adjusted accordingly. We're also seeing a phase into this component. If we start in the lower right corner, we see that groups of 100 or more have the potential for an upward adjustment to their value modifier, a downward adjustment, or no adjustment at all. The maximum penalty is -2%, which matches the penalty for non-participation, and the maximum bonus earning is +2%. For groups in the size ranges of 25 to 99 and 10 to 24, the penalty does not exist. Their quality and cost measures will be evaluated the same as the large groups, but they will only receive an upward adjustment to their value modifier or no adjustment. The current proposal in the Federal Register recommends to add the potential for downward adjustment for groups of 10 or more for payment year 2017, which is performance year 2015. And I expect that to be included in the final rule governing the value modifier program for 2017 payments. Now, as we bring our focus back around to the CAHPS measurement specifically, you'll notice that for the 2016 payment year, groups of all sizes have the option to include the patient experience measures in the quality tiering calculations. If you think your CAHPS scores will help your overall quality score, then you could choose to have them evaluated. If you think your CAHPS scores might not be where you want them to be just yet, you don't have to include them. Patient experience measures are being phased in for VM as well. The proposed rule for 2017 payments suggests that patient experience measures will be required for groups of 100 or more. In other words, your CAHPS scores for your medical group will begin having a financial impact when you do the survey with your 2015 patients. In other words, the answer is next year. Next year. This starts to count next year for the groups of 100 or more. And we can expect the requirement to extend to smaller groups in the future years. Finally today, I want to show you a little more about these upward and downward adjustments. This is not like value-based purchasing on the hospital side. In that program, several measures are scored for points, and then the whole thing is summed up to one number that drives your incentive rate on a sliding scale. For the value modifier, your 9 or more selected measures, along with 3 outcome measures, will be rolled up into a quality score. And then CMS will also calculate a cost score for your group. And let's just say there's a lot of math that goes into that cost calculation. Each of those 2 composite scores will then be compared to the scores for all other groups, and your scores will be categorized as high, average, or low. This table shows how the relationship of these 2 categorizations will determine your adjustment. High quality and low cost are the most desirable results for each of these axes, so that's where you'll find the greatest value modifier. On the other end, low quality and high cost are the least desirable results, and this is where we see the maximum -2% penalty. If you are average on both quality and cost, you'll receive no adjustment, and you'll continue to be paid for Medicare claims at the usual rate. I hope this has been a useful overview of the new value modifier payment approach for the Medicare fee-for-service physician payment system. We've just scratched the surface here, and again, I encourage you to visit the CMS websites I talked about for more details and explanation. So Nancy, what questions have we received from our guests today?
Thank you, Jan. As always, great presentation. Lots of good information there for everyone. Before we get started with the questions and answers, I just have a couple of points to make. First of all, if you do have a question, please make sure that you type it into the questions box that we have there for you, so you can ask any questions that you have for Jan. Also, a couple questions have already come in about the PowerPoint and the webcast being available, and I will send those out to everyone who has registered, so be on the lookout for the PowerPoint slides, as well as a link to being able to view this webcast later. So if others that were interested in viewing the webcast weren't able to make it at this time, you can certainly share that link with them, and then they'll be able to watch it at a later date. Also, there is another webcast in this series, a couple more in this series, so be sure to register for that. And Jan, what was the date on the next one?
October 8th. Excuse me, October 8th.
October 8th, again at 1 o'clock, so be sure to register for that if you haven't already. So let's take a look at some of the questions that have come in already.
Sure.
Our first one. In the last presentation, you mentioned becoming good friends with our GPRO or PQRS coordinator. I've tried finding that person, but I'm getting nowhere. Do you have any suggestions as to who would be a likely candidate for that position?
I've had this conversation with lots of people, and what I recommend to them is to head over to like the medical group administration offices or something and just start shouting these acronyms and see whose head pops up. And the person whose head pops up, because they know what those things mean, is probably the person that you need to talk to, right? If you're not sure, if that's not ringing a bell for somebody, then maybe try the quality director or quality manager for that group. Whoever is responsible for reporting the clinical measures may be that person that you're looking for.
Okay, great. What are considered the patient experience measures that you referred to as part of the quality tiering measures?
Yes, there were, you recall I talked about 9 domains or 9 categories. Sorry, there were 6. 6 domains that you have to pick from. You have to have measures from at least 3. And I mentioned that there were, 200 plus measures that are available to choose from. The CAHPS questions are some of the measures that will qualify for the patient and caregiver centered measurement. That's hard to say. But there are other measures, we'll call them clinical or chart abstracted measures that fall into that domain as well. Some measures related to pain assessment for patients with particular conditions, possibly some care treatment planning, again, for patients with different conditions. There aren't a whole lot relative to some of the other categories, but there are more measures than just what's in the CAHPS survey.
So there's a lot.
There's a lot.
And you kind of got your tongue tied. I was thinking maybe you could just talk in acronyms all the time. That wouldn't happen.
Right. And I'll say too, just to make sure people are aware, that measure list will change every year. So every year CMS is evaluating these measures and what it's telling them. They'll take some measures off. They'll add new measures as they come in too. So we want to keep up to date with what the current available measures are.
Okay. I think this is a different question. Explain again the quality tiering as related to the value modifier.
Right. Let me go back. I'm going to go back a couple slides. Let's go back to, we'll just go back to here. So the quality tiering, I would maybe describe, is the framework or the means by which CMS is evaluating performance and determining if you're going to I need to go ahead one more. Determining if you will be earning additional money or losing money. So quality tiering, rather than, I mentioned the HCAHPS scale and how for HCAHPS and value-based purchasing, there's a linear scale. Everybody's falling at different points along that line. This program is starting out by just putting results into buckets of high, medium, low. And so these tiers are these high, medium, low categories that are used then to evaluate the value modifier and determine the value modifier that will be applied to your reimbursement rates in the future. Yeah.
All right. See here. Some of these are just questions about whether or not the webcast is going to be available, so I'm just trying to get through to the ones that you would need to answer. You mentioned, again, that one is about the webcast being available. When you talk about groups with 10 plus professionals, does this include even the groups with 100 plus professionals or just 10 to 99?
Yes, let me clarify that. There were a few slides, and this is referring to the rules for 2016 as well as the proposals for payment year 2017, when we refer to 10 plus eligible professionals, that means 10 all the way up to the well over 100 ones. So we're really talking about the only groups that are left excluded from this program are those very small groups that have fewer than 9 eligible professionals in them.
Okay. And do I understand this correctly that the most we have at risk is 2%?
For payment year 2016, yes, the most that is at risk is at 2%. It is proposed for payment year 2017 that will go up to 4%. And whether or not will be future proposals to make that higher, or if it's going to stay at 4%, we don't know yet. The proposed rule was issued in July. We anticipate that the final rule that will appear in the Federal Register and set this program for calendar year 2017, that final rule should be published in the Federal Register, I would say late October or sometime into November. And so we'll be watching for that, and we'll be sending information out to everybody when we see that as well.
Okay. And it looks like you've answered all of the questions that have come in. So again, thank you, Jan.
You're welcome.
Great
You're welcome,
presentation.
everyone.
And hopefully we'll see you again on the 8th, right?
Yes.
October
yes.
8th for the next installment. Have a great day, everyone.